Hi, I'm Dr. Raj Chandwaney, and it's an honor for me to share this case for you all for CTO Plus 2025. I do not have any financial disclosures relative to this presentation. This is a 56-year-old gentleman who is referred for right coronary artery chronic total occlusion percutaneous coronary intervention by another colleague in my community. The patient is experiencing class 3 angina despite optimized medical therapy. His workup led to a myocardial perfusion study which did reveal significant ischemia in the territory of the right coronary artery. His ejection fraction is normal. There's no significant valve disease. A subsequent cardiac catheterization performed by the referring physician is remarkable for a right coronary artery in-stent chronic total occlusion and mild non-obstructive residual coronary artery disease. The patient's on good anti-anginal therapies. His past medical history is remarkable for right coronary artery and right posterolateral artery drug-eluting stent placements back in 2019. He had an additional right coronary artery drug-eluting stent placed in 2020. He has classic risk factors including hypertension, hyperlipidemia, diabetes, a family history of coronary artery disease. He does have morbid obesity with a body mass index of 44, which is unfortunately very common in Oklahoma. His vital signs show that his anti-anginal therapies are optimized. Physical exam is otherwise unremarkable except for the obesity. His EKG does not show any Q waves. This is a single guide catheter shot of the right coronary artery chronic total occlusion, which appears to be an in-stent chronic total occlusion. A dual guide catheter angiogram gives us a better sense of the length of the chronic total occlusion, which appears to be 50 to 60 millimeters long. I initially approached the chronic total occlusion using antegrade wiring. I'm using a Rader intracoronary guide wire inside of a turnpike microcatheter with a 7 French trap liner inside of a 7 French AL guide catheter. We were able to make some progress with our Rader wire, but we encountered a lot of resistance in the mid-segment of the vessel. And here you can see it appears that our Rader wire has actually left the architecture of the stent and is in the subintimal space. I was still hoping to achieve true lumen wiring. I switched out for a cross-boss catheter with the hope that the cross-boss would remain in the true lumen and get past that area of resistance, but I was not able to advance or spin the cross-boss catheter beyond that area of resistance. Here, I'm performing a Carlino injection through the cross-boss catheter with the hope that the Carlino would allow us to spin the cross-boss beyond that area of resistance. Despite use of the Carlino technique, I could not advance my cross-boss catheter beyond that resistant lesion. I actually switched back to the turnpike microcatheter, tried several different wires including a Confianza Pro 12, a Hornet 14, and Gaia Next Gen 3 wires to see if I could penetrate that resistant area and cross the CTO and the true lumen, but those efforts were not successful. Therefore, I decided to utilize a power knuckle technique. Here you can see I've advanced a 3.0 by 20 millimeter angioplasty balloon. I've inflated that adjacent to my turnpike microcatheter, and then I'm forming a knuckle using the Rader intracoronary guide wire. I think I should point out here that a Rader wire is more likely to form larger knuckles, and that was my goal here, to form a large enough knuckle that is unlikely to leave the architecture of the stent. I then carefully advanced that power knuckle. Here you see the power knuckle being advanced across that highly resistant area in the mid-segment of the vessel. Here you see the power knuckle being advanced even further towards the distal cap of the chronic total occlusion. At this point, I switched out for a Suzuki dual lumen microcatheter. I advanced that over the Rader intracoronary guide wire, and then I used a Mongo intracoronary guide wire in the second port of my Suzuki, and here you see me advancing that Mongo wire beyond the distal cap of the CTO. I performed a contralateral angiogram, which confirms that the Mongo intracoronary guide wire appears to be in the true lumen of the vessel. At this stage, we performed intravascular ultrasound-guided angioplasty and placed 2 drug-eluting stents. An excellent final result was achieved. In conclusion, although power knuckling is most commonly used for balloon-assisted subintimal entry to facilitate antegrade dissection reentry techniques, power knuckles can also be used to facilitate true lumen crossing of highly resistant in-stent chronic total occlusions. Thank you for your interest in this case.